Hi everyone, my name is Sylvan and you're listening to the Sylvanas podcast. On the podcast today, I've got renowned osteopath David Lintonbon. Now, I'm really lucky, really thankful to have him on because David brings such a wealth of experience. He's been working in the industry for over 35 years. He's a published author, he's a senior lecturer, and quite frankly, he is the king of HVTs. So, thank you so much for joining me today, David.
And thank you for having me on the show, Sylvan. It's very good of you.
Yeah, thanks. And so, how we met, David, was you were actually my lecturer at British College of Osteopathic Medicine.
That's correct. Yes, it was. All those years ago.
It feels like a long time ago.
Yeah.
And since then, I've spoken to lots of different osteopaths and also been mentored by you. And so it's incredible to sort of see this lineage of osteopaths that you sort of, discovered and taught and imparted all your knowledge to.
Well, I wouldn't say all, but I do my best.
Now, one of the reasons I was really looking forward to talking to you is because you are doing a CPD on June 14th, but we'll come back to that a little bit later. So one of the reasons I wanted to get you on the podcast, David, is because you're such a wealth of information and knowledge about sort of things like TMJ and jaw pain.
Mm-hmm.
I really wanted to talk to you about what your sort of view on it was and how you work with those, bone areas that a lot of people tend to have difficulty with.
Yes, the TMJ itself is an area of much dysfunction. A lot of people, when they have problems with the TMJ, there are a number of reasons for it. Sometimes this can be that there are certain teeth missing at the back of the mandible, which means people sometimes have a bit of an overbite. This may require correction through dental work first, before you can actually sort of start to work on the area itself. Or, looking at the other extreme, people have perfect dentition, and of course from there they may have literally a very tight TMJ through sort of, undergoing various dental corrections. So the jaw is forced open excessively, and as such you get a lot of muscular contracture, even problems with the articular disc, and from that we need to be able to assess what's going on or sort of, how we can correct it accordingly. Also, people have problems as a result of trauma. Falls onto the face can damage the mandible, multiple fractures can even occur, and if they're not corrected accordingly, then the person's always going to have issues with the TMJ because it will sit in a slightly malpositioned place. Night stresses, pain can emanate from that. Bruxism, of course, where people sort of, tend to chew their teeth at night. This is not uncommon. In fact, it's probably more common now than it ever has been. So these are a number of issues that we have to encounter. It's a very complicated joint, and as such, it can be a source of much dysfunction and much pain, particularly head and even neck pain as well. So when we look at it, we have to look at it from both the exterior, so looking at the musculature attached to the skull itself and how the actual sort of jaw works, looking for the various deviations, the clicking that happens, and also looking at how the jaw functions by looking at the musculature of the anterior part of the neck attaching to the mandible. Also, from there, we look at the inside of the mouth, palpating the specific muscles of the jaw, so the lateral pterygoid, the medial pterygoid, and of course sort of temporalis. So looking at these muscles and trying to achieve a form of symmetry through various osteopathic techniques that we use, then this is going to be a very useful exercise. But the elimination of maintaining factors has to be achieved first of all. And as I say, some of that can come about because of various dental malocclusion issues. These are very important. So sometimes working with a very good dentist is paramount to getting our patients on the road to recovery. Of course, there are also underlying pathologies that occur. These can be very difficult. So if you do have a patient who has got osteoarthritic change, for instance, then the actual asymmetry of motion is going to be because you're getting malocclusion on one side and total asymmetry of the jaw when it closes. So the patient's jaw will move over to the side of dysfunction. And this causes all sorts of havoc with the muscular control, particularly unilaterally on the side of dysfunction. So from that perspective, you might find that the patient requires surgical intervention. So then you're going to have to refer the patient on to actually get these problems resolved. If they're not, then the continuation of pain and dysfunction will continue. Thankfully, these sorts of conditions tend to be rather rare, and as such, we can then deal with asymmetry as a result of altered muscular tone. But that altered muscular tone may not just come from the side of the jaw or the side of the head. It may be being maintained because the patient has a short leg, resulting in a scoliosis. That scoliosis is going to end at the occipito-atlantal joint. So you think about how the scoliosis will then affect the actual balance of the patient. That balance of the patient is coming from the actual musculature between the head, the neck, the upper part of the back, and by maintaining balance, because the patient's always got to look forward in a symmetric manner, then of course compensation will occur, but that occurs up to a point, and then after a certain point, then dysfunction will occur because you're getting over-contracture on one side. So dealing with with what has been termed the stomatognathing system, how the head, the jaw, the cervical spine, and the upper back actually works all in conjunction with one another, is very important indeed. And you'll find that there are many faults that require correction before you can even start working on the jaw. Leg length discrepancy, for instance, this may come from the arch of the foot may have dropped on one side. There may be structural leg length discrepancy on one side, which may require a heel lift. Or we may have a short leg or a altered leg length, which is coming from a torsion of the pelvis. That will then give you a functional scoliosis. And of course, all these will lead to dysfunction of the jaw. What we need to remember is that the jaw itself is free-flowing, so it's always going to centre itself. So these things have to be taken into consideration in our assessment, evaluation, examination, and further treatment, and looking at various exercises that we need to do. But you will note there are many dysfunctions that occur with the TMJ. And these may also be underlying pathologies as well. It's not uncommon for patients to have facial-maxillary carcinoma, which can actually spread into the area. And obviously that's going to cause all sorts of havoc. Looking at that, obviously that's a question of referral. This is not something we would deal with, but we may deal with the aftermath of perhaps chemo and radiotherapy that has been used to treat that patient, and obviously working on the patient's jaw, both intra and extraorally, then can alleviate and ease the tremendous amount of discomfort that patient may have. So looking at things post-operatively is very important. Also, we may have issues where the same thing is where patients have had, jaw correction as a result of maybe an aesthetics issue. Some patients have an underbite or an overbite. This may be because the actual patient's mandible has either been inhibited during the growth phase or even has excessive growth. But as a result, then of course the patient's jaw is not going to fit correctly with its upper sets of teeth. So you're going to have issues there as well. And it doesn't take much to actually sort of throw the actual mandible out of alignment, for want of a better word. You treat sort of, people who sing, for instance, small motions can mean an awful lot when that patient is trying to hit the right note. All right, if you deal with opera singers or just singers in general, then you'll find that sort of, the anterior strap musculature in relationship to the hyoid and the movement of the mandible is very, very important. Small movements or small malalignments or overcontracture of muscle can mean the difference between hitting the right note and not. All right, and if you're not hitting the right note as a singer, your career is in jeopardy. So being able to deal with that is not only sort of, good for the patient, but it's also good for morale as well. And it's probably sort of, one of those treatments that you find that the actual patient recovers very quickly indeed. And it's quite a privilege working with some people, particularly sort of, at the top of their profession, particularly sort of in the field of singing. And it's probably one of those cases that very few people in the general public would give any credit to whatsoever. Osteopathy itself is pretty much, hidden, I think, when it comes to that aspect. But sort of, we do our best to promote our services accordingly. So yes, there are many problems with the TMJ, and of course, sort of, we deal with them accordingly. But we also mustn't forget that the TMJ, if it becomes dysfunctional, can also trigger problems elsewhere. If we have sort of, problems with sort of malocclusion, then of course that might sort of, result in, musculature building up on one side of the head, neck and face. This can affect sort of, the cranial rhythm because you're compressing the actual cranial bones on one side of the face, and this might affect the flow of CSF, generating pain not just in the head, but also in other parts of the body as well. Also, when we look at the TMJ again as a dysfunctional state, the knock-on effect might also affect the upper cervical complex. If you look at the OA joint and the AA joint, these joints in a way sort of, act as a bit of a gyroscope in relationship to the TMJ. So if you have problems with these particular joints, all right, in relationship to the TMJ, then the patient might end up sort of, with a tremendous amount of upper neck pain. And that might result in compression of the greater occipital nerve, giving the patient a tremendous amount of occipital neuralgia. And we see this quite typically these days. A lot of people, if they're working at a computer, they might sort of, rest their hand on their jaw and they're looking over to one side. And, over a period of time, a couple of years perhaps, you're going to cause sort of, a certain amount of dysfunction to one or even both TMJs. And then, of course, the actual anterior head carriage, contracture of musculature will affect the movements of the TMJ and vice versa. So, of course, these days, many people are working at a computer or working with electronic devices. So the head is nodding forward, and that's going to affect sort of, how the free-flowing movement of the jaw operates. And, of course, continual movement or anterior head carriage of the patient, particularly if they are involved with IT, for instance, these are becoming very common problems. Not just with the TMJ, but as I say, the anterior strap musculature and the anterior musculature overall of the cervical spine. Likewise, patients that also have undergone a whiplash injury, for want of a better word, or hyperflexion extension injuries to the cervical spine as a result of trauma, not always as a result of a road traffic accident. This can also be as a result of some form of trauma in contact sport, for instance. Things like sort of, football, rugby, martial arts. These can also have dire consequences on the cervical spine as a whole. What we've found is that you find patients that have had hyperextension injuries to the cervical spine, the actual anterior musculature, particularly the longus colli and sternocleidomastoid muscles, they will go into a shortened state. They contract. This maintains the head in a anterior head carriage. And of course, that places a lot of stress and strain, not just locally in the anterior part of the cervical column, but it's maintained by contracture of the posterior musculature as well. But the important thing to note here is that if you get an overcontracture to longus colli, you're also going to compress the anterior cervical complex. So biomechanically, you can actually trigger a migraine type headache. So how does this actually work? Well, what we've seen with patients who've received a trauma to the cervical spine is that the longus colli muscle tends to shorten. And in certain individuals, over a period of time, particularly if they've received a hyperflexion injury, you get osteophytic lipping to the anterior parts of the vertebral bodies, particularly in the mid and lower part of the cervical spine. Well, of course, you're going to have problems with this because the longus colli muscle, if it contracts, it will actually compress the cervical sympathetic plexus, and that in itself will cause an overloading of sympathetic discharge. If that continues, it will affect the blood flow up to the brain. Overcontracture of the cervical sympathetic plexus itself has the effect of causing contracture to the arterial supply to the cervical spine. But not just the cervical spine, also to the brain. So you're reducing blood flow momentarily. But over a period of time, that cervical sympathetic discharge doesn't carry on indefinitely. It does actually end up crashing. And then you end up with a problem because the parasympathetics work unopposed, so you have an imbalance of the autonomic nervous system. This in itself further reduces the blood flow to the brain, and in doing so you end up with the massive ischemic headache because you've got massive vasodilation to the carotid arteries. This means that the blood pressure has to increase to try and force blood or oxygenated blood to the brain. However, it never achieves sufficiency, so the patient always ends up with that massive throbbing headache with the visual disturbance that is so typical of classical migraine. But this is only one typical example. But obviously, as we know the human anatomy quite well, we can easily work into the longus colli muscle, relax it. And in a way, you can even teach the patients how to self-treat their own longus colli muscle and get them to relax it off. So if they feel the symptoms coming on, they can actually do some self-massage to actually work on longus colli, relax it off, and hey presto, you start to ease the symptoms of migraine and stop it in its tracks. And most of the time, it can work very well. So if you have patients who do have ongoing issues with migraine, do look at the longus colli muscle. It can be a big source of biomechanically induced migraine. I know there are many other causes, particularly from various food substances to various different types of aromas, etc. There are many trigger factors. So I'm only talking about one that we can seriously influence as practitioners. So of course there are other issues as well, particularly when we're looking at the brain stem and the cerebellar area. All right, compression there can be affected by contracture, and again, all right, issues with the OA, AA facets, which then leads to, as I say, contracture of the musculature, and obviously loss of motion in that particular area. So these are quite ongoing issues for many people. So working on the facets of the upper cervical complex in particular can be very good at also working on the musculature by actually carrying out various manipulative techniques. You can actually help to relax the muscle tissue off because you're stretching the Golgi tendon organs of the muscles that cross those particular joints, and in doing so you get a nice reflex relaxation of those particular muscles, and in doing so you're getting decompression, particularly to the greater occipital nerve. So reducing, greater occipital nerve impingement and then reducing occipital headache. A very useful thing to get to grips with. So there's a selection of various aspects to it. So I do hope that's been very helpful to you. I'm sure there are many other facets of this that we can talk about. So how are we doing so far?
Yeah, hugely. And what I really taken away from that is the holistic ways that you can approach this area and then causes for problems in the jaw area.
Yes.
Which I hadn't even factored in.
Mm-hmm.
So it's been really enlightening.
Yes, there are many aspects to this, and I think a lot of people don't realise that as osteopathic practitioners, we can influence that area for the good in a number of ways. I talk about carrying out manipulation to that area, but there are other, more straightforward approaches by doing gentle mobilization, for instance, and working through muscle energy techniques into the area. All these play a part, and I think we should really try and incorporate other aspects to the treatment of the area as well. If somebody is very acute, it can be very difficult sometimes to actually palpate or carry out muscle energy or even gentle mobilization. The patient just reacts to it in a very bad way. So we have to back off and think again. Obviously, using other modalities, and then this is where dry needling or medical acupuncture can come into its own. There are various acupuncture points that you can use to actually ease the pain of greater occipital, neuralgia, TMJ issues, and also helping to cope with the long-term relaxation of muscle tissue in the area, particularly if there's been a spasming of muscle or there's some inflammatory process going on, where you can't use direct techniques, but you can use, as I say, a form of medical acupuncture where you can actually needle into the area to relax muscle tissue off, get that endorphin release, which then is triggering the body's own natural process for pain control. Endorphins are there for a reason. When you pop a needle into somebody, you get a massive amount of endorphin release into the area. And of course, that's very useful because you're helping to reduce pain and inflammation by stimulating the body's own mechanism. And that's a very good thing because you can actually help ease a tremendous amount of head, TMJ and neck pain just from that. As I say, particularly useful in the acute patient. So that tends to incorporate another modality as well. And, these things can be done accordingly, treating the acute patient. And then as the patient's issue starts to ease, then of course you can change your approach by using more direct techniques. And that can be very helpful for a lot of people.
Yeah.
So I hope that sheds some light on that incorporation as well.
Absolutely. And one of the things you talked about, and I really appreciate that you linked, TMJ issues with headaches to as somebody who has TMJ issues myself. Headaches is something that, is so prevalent with a lot of people who have this type of issue, but isn't always linked by practitioners. And so I really appreciate that you've been able to do that.
Good. Hopefully we'll shed some light on it as a whole. But, we also need to make sure that, practitioners are safe and, not all headache is coming from an MSK issue. So hopefully people will be able to spot problems that we can't deal with as well. Red flags do occur and obviously, thankfully they are quite rare, but, if a patient comes to us and, that they don't respond to treatment, we should also have the wherewithal to actually refer that patient for maybe a CT or an MRI scan to make sure that we haven't missed anything. And, that just makes the practitioner more rounded and more focused on their approach. So yes, we must also be careful to ensure that sort of, patients, are dealt with in the appropriate manner. We also need to think that sort of, when we have a TMJ patient, we do have to work inside the mouth as well. Now, most patients are very happy with that, but it's also an important aspect because you're going into a sensitive structure that you do need to gain the consent of the patient as well. And we get patients to give us written consent to work inside the mouth, whereas the majority of people sort of who come with a TMJ problem, we would expect that you would work inside the mouth anyway. As I say, in this day and age, we do have to respect the right of the patient. I'm not saying we haven't always, but, you do need to sort of ensure that the patient is happy with the technique. So you have to explain what you're going to do. And, it's always good to have an anatomical model handy so that you can show the patient where you'll be placing your hands, where you'll be placing your palpatory finger as such, especially if you're going inside the mouth. All right. And you have to explain to the patient it's not always the most comfortable of procedures. All right. So, explanations to the patient, I think, are very important indeed. We can't just get in there and get on with it, which they may have done years ago.
Definitely. And have you seen a change in the type of patient that might be presenting with TMJ pain? Is there a certain demographic?
Well, I think the problems are getting younger and younger. I mean, patients who we saw with TMJ issues a number of years ago sort of, tended to be sort of, maybe 40, 50 plus. All right. There may be sort of, a history of issues that they've had over the years. But of course, now you find that sort of, patients are presenting at much younger ages with TMJ issues. I'm not saying we never used to treat people in their 20s with TMJ problems, but I would say that the actual sort of average age of people coming in with TMJ issues has dropped dramatically. Well, I put that down to a number of factors. One is that sort of, people are sort of, much more aware of, their teeth, and people go and see a dentist on a much more regular basis than I think they ever have done. Of course, the aesthetics industry is very, very big now. And of course, sort of, the majority of patients that we see, sort of, they may have had, a tremendous number of dental procedures in a very short space of time. These days, people don't put up sort of, with missing teeth or even going in sort of, for gold teeth and the like. People want to have sort of, a good set of, overall very functional teeth that look nice and they're not all crooked. And there's nothing wrong with that, but, there are pitfalls that do occur. If you are sort of, having dental implants, or if you're having sort of, a lot of dental work done, then you have to be aware that the actual mouth is held open for, quite considerable times. And if the mouth is wedged open, and it sometimes is with a rubber wedge, they're put into the base of the mandible to keep the jaw open so the dental practitioner can do his job, then of course sort of, you've got to think about the consequences of that afterwards. Stresses and strains occur, and it's no good having a perfect set of teeth if the muscles that work that jaw and teeth are not functioning efficiently also. And nobody wants to be in any pain with it either. I mean, people used to get sort of, all sorts of issues in and around the TMJ, but mainly as a result of trauma. But now we're seeing it as a result of more to do with the aesthetics industry, with sort of, people having all sorts of dental veneers, dental implants. Obviously, sort of, that sort of, pays a price, so to speak, and I would say that, our demographics have changed quite dramatically in the last 20, 30 years. Sort of people who've got TMJ problems as a result mainly of a trauma, and now sort of, that's now gone to a much younger age as a result sort of, of the aesthetics industry. And also, we've got to think about sort of, people who are having sort of all sorts of, fillers and this and that and Botox and, the like. What's going to be the long-term effects of that sort of, on the area? When people sort of, have injections in and around the eye, you're very close to the TMJ. So what's the effect of these fillers and, various sort of, injections people are having? What are they going to be like in 20, 30 years' time? So there are different ways in which the jaw has been affected now, I would say. So it's a very pertinent question, and one that sort of, has seen a big change in our approach to treatment, I must admit.
I'm glad you talked about the aesthetics, because I'm certainly seeing not a whole lot, but a few patients in my NHS practice who have had either very specific dental work done, like for the ears, and some of them actually had fillers along the jaw, for example, and I had to be really aware of asking those questions, because I wasn't always
very much so.
asked the questions as a student.
Yeah, I think that's very important. And also, you've got to think about when you're actually sort of working inside the mouth, you've got to be careful of things like caps and crowns. You've got to think about the patient's teeth as well. All right, sort of, you don't want to dislodge anything. You shouldn't be. So, those techniques have to be correctly taught and implicated as such. So it's very important when we're working inside the jaw, we have to have a responsibility, to think about the structures that are in there, so that we don't sort of, upset somebody else's work, particularly if they have sort of, gone down that sort of, aesthetics route. And as I say, that number has really sort of, gone off the scale, I would say.
Yeah. You talked earlier about sort of, working with acute cases and maybe working around the area using things like trying needing, for example. What would your approach be with more of a chronic type of case there?
Well, of course, the chronic cases are there, and of course you're going to see many chronic cases over the years. As I say, at one time, sort of, it was mainly the chronic problems that we used to see. But those chronic problems, you've got to think about sort of, what's maintaining them. So, as I say, a lot of it might be that, going back over the years, all right, a lot of the time that might be because, a lot of teeth have been removed. And of course, if they're not replaced, then of course, if you've got a lot of molars that have been removed on one side of your mandible, and of course, when you close the mouth, then of course that mandible is then going to move closer to the upper set of teeth, causing a contracture of the muscles operating the jaw on that side. So of course you're going to have asymmetry. So that causes chronic pain in the TMJ because you're getting an overbite or an over deviation of the jaw on sort of chewing and talking, etc. So of course one of the things that sort of can be helpful in those situations is using a mouth guard. We find that sort of people sort of can get very expensive mouth guards, but they're not sort of they're not sort of the be all and end all of things, and most people don't really need an expensive mouth guard. You can actually sort of show people how to use a standard sort of silica mouth guard itself. You can buy them on the internet sort of for not a great deal of money. And all they have to do is just warm them up sort of in hot water, put them into the mouth, and obviously sort of bite down accordingly. And that sort of can be a very useful intervention. So working with chronic patients, it's making sure that the patient has sort of the right tools for the job. As I say, sometimes that's a question of maybe you've got to refer that patient on. Maybe they will require other types of treatment first before that TMJ settles down. And, you may have to refer the patient back to a dentist to ask about sort of, where those teeth are missing. Do they need to be replaced by a cap or a crown or even sort of, as I say, when you go for implants. So again, it depends on the actual age of the patient, the chronicity, but more importantly, it's what's maintaining the issue. And that's where it sort of comes to us to try and sort of push the patient in the direction they need to go. But also sort of teaching patients exercises can be helpful. As I say, you've got the mouth guard issue that can be resolved very easily. And I think sort of getting patients to do sort of some work on their own jaw, gentle works, even sort of working on acupressure points in the area can be of great help. Even sort of some patients have the wherewithal. You can show them how to carry out inhibition to their own lateral pterygoid, so they can work inside the mouth as well. So that can be very helpful to your chronic patient, teaching the patient the right exercise, how they implicate and use that exercise in the correct manner. And I think that's very important. Most patients are obviously sort of very passionate about their own pain and they want to get rid of it. So, it's down to us as practitioners to tell them and actually instruct them how to use self-directed exercises to help with the chronicity of the problem and how they can maintain it themselves. And I think that's very important. Self-directed exercises for patients are very important indeed. They can help the chronic patient nice and easily.
Yeah, I agree. I found when treating a lot of patients that they want to be taught things to be able to self-manage first.
Yes.
And they want to go away from your treatments with something to do rather than, waiting until the next appointment, for example.
Oh yes, that's very important. I think very important indeed, Sylvan, because patients, they don't want to be in pain all the time. They come to see you because they want to get rid of it. So as I say, it's down to us to try and help them the best way we can. So that's my personal opinion. I'm sure many other people have got opinions in other ways, perhaps.
Now, one of the things I mentioned earlier in the podcast was that you are delivering a specific CPD on sort of TMJ and headaches, and that's happening on the 14th of June at the British College of Osteopathic Medicine. I wonder if you could tell me a bit about what that entails and what will be covered.
Yes, that's right. It's not just delivered by myself, but also an Australian colleague. So Dr. John Marshall from Australia will be coming over, and he will be demonstrating his approach to the diagnosis, examination, and treatment of various common head pains. That will also incorporate the TMJ, and together we will be demonstrating examination, assessment techniques, all right, and how we treat the actual sort of TMJ and various common headache issues as well. So that will be sort of using a variety of techniques, which of course sort of we will be teaching the actual participants. Most of those participants will also sort of be familiar with various dry needling techniques, and we are going to cover some dry needling techniques to help alleviate acute headache and TMJ as well. But of course, sort of the TMJ techniques that we will be using will also be sort of intra and extraoral, and we will be looking sort of at the cervical column and how that sort of influences headache. So of course, headache itself is not just purely sort of in the area, but it's what generates head pain. And that could be cervicogenic headache, so problems with the cervical spine that emanate up to the cervical spine and beyond up to the actual cervical spine itself. And of course, through the TMJ, emanating in sort of head pain as a whole. All right, so we'll be covering it quite extensively throughout the day. So common sort of problems that cause headache, as I say, common problems that cause sort of TMJ dysfunction, how we examine and treat accordingly. So we'll be running through a whole series of techniques to help sort of diagnose and treat these problems. We'll also be looking at sort of about case history taking with sort of, patients who present with head pain. So how to sort of, differentiate between sort of, what might be a common MSK problem, but sort of, also looking at sort of, what may be something more sinister, and how we can actually sort of differentiate between sort of, some problem that's MSK orientated as opposed to something which is more sinister. So that's going to be sort of, the emphasis of the day, how we actually sort of distinguish, all right, between sort of, MSK issues and non-MSK issues. Knowing when to refer is a very important aspect of what we do. Just because someone presents with pain doesn't mean to say that you can treat all of it. It may be there sort of, but it's not something that you can deal with. And sometimes you require further information, which might be via an MRI scan or a CT scan. And of course, sort of, you would then refer the patient for that first. And then before you get sort of, the actual MRI back, you wouldn't be able to treat that patient. So you'd have to sort of, get the report back first before you then sort of, proceed with further examination, special testing, and then sort of, the treatment plan on the end of that. So that's the emphasis of it. It's really sort of, safety and sort of, how to identify those red flags. And of course, sort of, how we distinguish between the two. So that's a very important aspect to it. So all those who can make it on the 14th, all well and good.
Yeah, it sounds like you're going to be covering a lot, and I think that's what I'm looking forward to.
Mm-hmm.
I've already signed up.
Yeah.
I think as students, and when we're studying in various different osteopathic universities, we do cover it a little bit, but I don't think we cover it to the extent that, we feel confident going into practice and really delving really deeply into that kind of work. And I think CV courses that you do like this is so important to be able to develop more knowledge in the area, and specifically when to refer.
Yes, I agree. That's paramount. I think sort of, this is where some people get into trouble because they think they can cure everything, or sort of, they think they can actually sort of deal with every pain that's presented before them. But as you and I know, that is not the case. All right, and I think sort of, it's to be an experienced practitioner, you've got to know when not to treat, and I'll emphasise that not as well, because not everybody who comes to see you is actually sort of someone you can treat, and I think sort of, for those of us sort of, who embrace that, it's very important indeed. Because unless you've got a complete thorough diagnosis of somebody, you can't really treat that patient. And I think sort of, we need to be able to ensure that sort of, safety is paramount. We can't sort of, just wildly sort of start treating patients if we don't have a complete diagnosis, because that would be wrong. So you've got to really sort of, sometimes take a step back, get further information before you proceed. That can sometimes be difficult. Patients can actually sort of be very demanding, and they say, well, I've come to see you because I've got this pain in my head. You say, well, I need further information before I can actually sort of treat you. And they'll actually sort of say, well, can't you do a bit today? You say, well, no, unless I know what's really gone wrong with you, I can't treat you. So we have to be sort of, quite firm sometimes with people, and sometimes they don't like it. All right. But sort of, if something went wrong, they would be the first to complain. And then you're the one who's going to be in trouble. So make sure that we're all sort of, safe and singing from the same song sheet, so to speak. All right. That's very important. Yeah. Safety is paramount, especially with headache.
Absolutely. Yeah. I'm wondering, where can people go to find more information about the course or any of the other courses that you do offer?
All our courses are accredited by CPD UK or FHT, All right, and they're all sort of, listed on our website. All right, sort of, if you punch in sort of, David Lintonbon CPD courses, they'll come up quite nicely. Or if you go directly to our CPD website, which is immcpd.co.uk. All right, so they're all on our personal CPD website. So everything's there, and sort of, you get an outline of each course. And by looking at the course itself, if it's the one that you want to do and it floats your boat, so to speak, then of course, sort of, you can book it online, and hey presto, we'll see you on the direct date as such. So very easy to book online.
Yeah, and I will say that you don't just offer sort of the TMJ and headache CPD, you do CPD on dry needling, on spinal and peripheral manipulation. So there's a whole host, and having done some of your courses previously, I thoroughly enjoyed that and gotten a lot out.
Thank you. Well, we try and make them as entertaining as possible, but also sort of, unlike sort of, some CPD courses, we always want to make sure that sort of, people assess and they understand why they are carrying out the techniques they're doing. All right, it's quite easy sometimes to actually sort of just show somebody how to do something, but you've got to understand why you're doing it. And this is sometimes, I find this an anathema. A lot of people come to us and say, well, I was shown how to do that, but I didn't know why I was doing it. And you think, that's very strange. Techniques are there for a reason. If it's a joint restriction, then you're dealing with that joint restriction, not just to improve the function and to reduce pain, but also sort of, to relax soft tissue off, and also sort of, to educate the patient as to why sort of, that occurred in the first place and what they can do to prevent it in the future. So I think this is where sort of, we move apart. That having sort of, a course which you're actually sort of teaching practitioners to carry out techniques and to understand why those techniques are necessary in the first place, and actually sort of why sort of, they need to be able to educate the patient into preventing them from occurring in the future. So that aspect of patient self-directed exercise, following any form of treatment is also quite important as well. In fact, it's a very necessary part of the management protocol of treating anybody, really, is prevention. And prevention is always better than cure, as they say. So, we wish you well.
And I will say that you don't just provide sort of paid courses, but you also have a host of free resources on YouTube. I mean, your YouTube channel alone has almost 12,000 subscribers, and some of the videos you have on there, I still watch every now and again. And I think there are some with like 500,000 views on there. So there is a lot of content put up there for free.
That's right. I mean, all of those techniques, it's an educational resource. Some of them sort of, are tried and tested techniques that has been used throughout the industry over many years. But it's not just the actual sort of technique that you will see demonstrated. If you also sort of, click on the more button, you'll also find, why we carry out these techniques. So if you're looking at sort of, a problem, say, with the cervical complex, then of course, sort of, there is a description as well, which actually explains why the technique is being used in the first place. All right, but also sort of, there are other descriptors in there that tell you about sort of, assessment, when to and when not to use those particular techniques. All right, and I think that's a very important aspect of it. So again, sort of, explanations as to why we would carry out the technique. All right, but also more importantly, why we would not use it as well. And that's also an important aspect too. So yes, do look at the Integrated Manual Medicine, all right, YouTube channel. It's very useful. It's a free educational resource for practitioners. And of course, sort of, if anybody has any questions about it, you can quite easily sort of, either leave a comment or sort of, directly get in touch with us via email. When the email is actually sort of on the description of every video that we post. So if you want to get in contact with us, it's very easy to do, and we look forward to receiving a comment. That would be very useful indeed.
It always solves the algorithm.
Oh yes, there we are.
Yeah, as someone who's building up my own YouTube channel, I would always try to get the numbers that you do and you get on yours. But thank you so much for spending
You're
the
welcome.
last hour with me. Genuinely, I've been able to get so much out of it, and just learning about your approach is always really nice to spend some time with you.
Oh, that's very kind of you, Sylvan. It's very kind of you to invite me onto your channel. But always remember, as practitioners, and we we osteopaths amongst us, all right, we do treat the body as a whole. It's not just about one bit. So that's why I like to emphasize that part. We do treat the body as a whole, and I think that is what makes our profession stand out from all the rest. Would you not agree?
Wholeheartedly.
That's great. Well, again, thank you so much, Sylvan, for inviting me onto your channel. It's been an absolute pleasure talking to you, and we'll look forward to seeing you in the not too distant future at our next CPD event, whenever that may be.
Wonderful. Thanks, David.
My pleasure, and look forward to seeing you soon.